session first speaker, Dr. Sami Sanjad. His topic is monogenic syndrome of salt-sensitive hypertension. Dr. Sami, please.
Good afternoon, and thank you all for staying this late. I know that, with time people get tired and start, wanting to take a nap, so that's fine with me. I think you're good quality, and that's what counts. I'd like to thank the organizing committee, and specifically Dr. Saleh Shurafa, for inviting me to this conference. Saleh has done an outstanding job in, getting all these fine people together, and I think I'll congratulate him for a very successful conference. My topic is about monogenic syndromes of salt-sensitive hypertension. It's well known that genetic factors contribute to about 40 to 50% of blood pressure variation. Yet, less than 3% of known genetic factors actually do exist that have been identified. In other words, we're still a long, long way to identifying all the genetic causes of hypertension. So there probably are more than just the single genes that we'll be talking about. We'll also probably have gene-gene interaction, epigenetic factors, etc. Okay, so it's working? Not working? Anyway, so this is the outline of my topic, of my presentation. We'll talk about when to suspect monogenic hypertension. In other words, when should you really think about it after ruling out secondary hypertension? We'll talk about some of the recently and not so recently described syndromes of salt sensitivity. We'll talk about the genetics and pathophysiology of these hereditary syndromes, which are very, very interesting, and we have learned a lot from them. And finally, we'll talk about the implications of salt sensitivity in the etiology and treatment of essential hypertension. So when do we suspect monogenic hypertension? After ruling out secondary causes of hypertension, which in children are usually due to renal parenchymal disease or renovascular disease, then we should strongly consider monogenic hypertension if it's an early onset, early life hypertension. You should keep that in mind. You should also consider the severity of hypertension. In other words, if the hypertension is very severe in a young child and refractory to treatment, then again, this should be an indication that you might be dealing with the monogenic Mendelian type of salt-sensitive hypertension. Family history is very important. If you have consanguineous parents, if there is a family history in one of the parents, particularly starting at an early age, this again should alert you to the possibility that you're dealing with a single gene related to hypertension. And sometimes suggested findings from the physical exam, for instance, a child who is failing to thrive, ambiguous genitalia, and so on, this might be, again, indications that you might be dealing with monogenic hypertension. And lastly, the biochemical abnormality, the laboratory findings can be very, very suggestive, particularly if you find hypertension with hypokalemia and alkalosis, and rarely with acidosis and hyperkalemia. This is a strong suggestion that you might be dealing with one of those syndromes I'll be talking about. Now, all these syndromes share one thing in common, in that they are all salt sensitive. In other words, they have a propensity to retain salt and do not excrete it appropriately. The salt retention takes place at 3 different levels. We'll be talking about this. In fact, I'll be repeating it throughout this talk. You might get bored because it's important to repeat what happens. So, first of all, there is impaired renal excretion that leads to sodium retention, increased extracellular fluid volume with the expansion of ECV. This stimulates brain endogenous wabain, and wabain finally, together with the stimulation of the adrenal cortex, generate a very interesting, get my pointer. No. Anyway, there is a new, not new, but an identified substance known as adrenocortical MBG, marinobufugenin, and this is a very potent vasoconstrictor. It acts actually on the sodium-potassium ATPase pump and leads to increased cell sodium, increased cell calcium, severe vasoconstriction, and hypertension. This substance is also known to promote diuresis, but when it's found in excess amounts, it doesn't. They don't work. See. No. Anyway, so this is the basic mechanism that underlies all the syndromes I'm talking about: salt retention, expansion of extracellular fluid volume, wabain secretion, marinobufugenin, which is a very potent vasoconstrictor, and this is how they develop hypertension. Now, having said that, there are 2 basic mechanisms for inheriting these syndromes. Most of them are autosomal dominant. In other words, usually one of the parents or grandparents has the disease, and only 2 of these are recessive genes. The dominants are listed here: Liddle syndrome, familial hyperaldosteronism, known as GRA, and there is 4 of them, and the Gordon syndrome and Geller syndrome. The recessive syndromes are the apparent mineralocorticoid excess, or AME, and the congenital adrenal hyperplasia. I will not be talking much about this. I think Dr. Al-Bayruti will be talking about endocrine hypertension tomorrow, so she will probably cover those in more detail. Now, again, as I stated at the offset, that these are all syndromes of extreme salt retention. And they all are related to excessive sodium transport across the renal tubules. This happens primarily at the level of the distal collecting tubules and the cortical collecting ducts. Okay, distal convoluted tubules, and there are 2 mechanisms by which this takes place, either due to increased sodium transport by a mineralocorticoid effect, or increased sodium transport independent of mineralocorticoid effect. In other words, in these 3 syndromes here, Gordon's, Liddle's, and Geller syndrome, there is a constitutive thing that helps the kidney absorb, regardless of a stimulus, to reabsorption. In other words, it's a genetic mutation within the transporter, within the channel, within the receptor that enhances further absorption. While in the other 3, syndrome of AME, apparent mineralocorticoid excess, glucocorticoid, remediable aldosteronism, and congenital adrenal hyperplasia, there is a circulating or a local mineralocorticoid that is actually leading the effect for salt retention. Again, I'm repeating myself, but this is just to show you the site where this actually takes place. Okay, this is, if you remember your anatomy, histology, physiology, you have a glomerulus that is not showing on this pointer, doesn't reflect. Anyway, the glomerulus, and then you have the area known as the NCT. NCT is a sodium chloride co-transporter that is a thiazide-sensitive transporter that enhances sodium reabsorption in the distal convoluted tubule. So these are very specialized transporters that are present in everybody. We all have those transporters. And they're very tightly regulated by the amount of sodium we eat. If you eat too much sodium, they don't reabsorb excessively. But in patients who have diseases that we're talking about, they may have mutations in this thiazide-sensitive or in the sodium epithelial channel further downstream in the collecting tubule. Okay, so these are the two types, or three types of cells, actually. The thiazide-sensitive distal convoluted tubule, the principal cell of the collecting duct, which has the sodium channels, and the mineralocorticoid receptor that is the one that mediates all this absorption. So we'll start with the first disease known as GRA, or glucocorticoid remediable aldosteronism, dexamethasone suppressible aldosteronism, or familial hyperaldosteronism type 1. This was originally described by Sutherland and then by Brahim Salti, who was a friend of mine, in the late 60s. And it presents with hypertension, a young child or a young adult, and it can be fairly severe and associated with the CNS complications, including strokes due to ruptured cerebral aneurysms. Hypokalemia is found in about 50%, and obviously hyperaldosteronism and low renin. So all these syndromes have low renin activity. They're low circulating plasma renin. They all have extracellular fluid volume expansion and suppressed renin. This is probably one of the easiest diseases to treat because they respond to glucocorticoids. You need to suppress the ACTH, and they respond very well to that. Or you can also resort to to spironolactones or mineralocorticoid antagonists. Now, the genotype was discovered more than 30 years later, and it turns out it's an autosomal dominant mode of inheritance, and it's actually due to an asymmetric fusion of two genes, the aldosterone synthase gene and the 11-beta hydroxylase gene. Now, this results in a hybrid gene that brings aldosterone under ACTH rather than angiotensin II. So the aldosterone will be secreted from the zona reticularis rather than the zona glomerulosa, and these patients develop sustained severe elevation of blood pressure. Typically, they have elevated 11 carbon oxidation products in the urine. Now, this is to show you what happens, and I'll not elaborate. These are the two genes, the aldosterone synthase gene and 11-hydroxylase gene in the upper part of the slide. They fuse, but during meiosis, they don't fuse properly, and this leads to the fact that ACTH, instead of, this is what's normal on the left side, ACTH aldosterone is usually stimulated by angiotensin II, whereas in these patients it's due to, it's stimulated by ACTH in the zona reticularis. So this is a continuing elevation of the plasma aldosterone level. So the other syndrome is Gordon's syndrome, is known as Pseudohypoaldosteronism type 2, and this is the only syndrome that I'm talking about that is associated with hyperkalemia. All others have hypokalemic alkalosis. These patients have hyperkalemic acidosis. We studied a couple of these patients, and all these are rare diseases, incidentally, but they have really taught us a lot in the etiology and pathophysiology of hypertension. So needless to say, this is all salt sensitive. Again, diagnosed at a young age. Hyperkalemia with a normal GFR, metabolic acidosis, which can be very, very tricky to diagnose, really. It's a hyperchloremic acidosis, a type 4 RTA, if you remember it. Again, low renin, no aldosterone, and even prostaglandins are low. We originally thought this was the diametrically opposite syndrome of Bartter syndrome. It turns out it is just not the case. It's actually the opposite of Gittelman syndrome, if you remember those syndromes. And a nice thing that they respond to low-dose thiazide diuretics. And then I'll show you why. Again, the genotype was discovered, again, many, many years later, 30 years later. Again, mostly autosomal dominant. There is only one variant that is recessive, and these are the chromosomal locations. And then it turns out there are some threonine kinases, some protein transporters that have a gain or loss of function that somehow accentuate or potentiate this transporter. Okay? And these last two, KUL3 and KHL3, were discovered only 4 or 5 years ago. So this is what happens in Gordon syndrome. Remember, I was telling you about the sodium chloride co-transporter in the lumen and the distal connecting tubule. Now, these transporters for somehow undergo a gain of function mutation and activate this transporter. So there is constant stimulation of the transporter to keep on reabsorbing sodium chloride. So they, again, through the same mechanism of salt expansion, of volume expansion, stimulation of the factors I mentioned about with vasoconstriction and hypertension. So there is gain of function of this transporter known as the WINK1 or loss of function of WINK4 that lead to activation or constant stimulation of the sodium chloride cotransporter. Now the next syndrome is pseudohypoaldosteronism or Liddle syndrome. Pseudohyperaldosteronism, sorry. This was again described more than 50 years ago. The phenotype, again, with the hypokalemic alkalosis, low renin and so on. And until recently, we didn't know how to treat those patients. They were treated with conventional antihypertensives until we found out that they're actually, the disease is due to gain of function mutations in the sodium epithelial channel. The sodium epithelial channel is located, as I showed you earlier, in the principal cell of the collecting duct, and this is tightly regulated by these subunits. So the increase in the number of channels is what leads to this sustained absorption of sodium. So what happens is that the mutations in the ENaC, or the sodium epithelial channel, will lead to increased number of channels, decreased degradation of the channels, so they remain open for longer periods of time. There is enhanced sodium reabsorption, increased potassium secretion, and again, the same old story, expansion of extracellular fluid volume with hypertension. So this is what happens at the cellular level. This is the normal cell on the left side, the principal cell and the collecting duct on the left side. And this is one on the right side where the channels, the sodium channels, have increased in number, and the PO, or the potential for openness, remains higher, so they keep reabsorbing sodium relentlessly, regardless of the stimulus. So this is what so this disease actually responds to sodium channel blockers, namely amiloride or triamterene. This is how they treat these patients. You don't need aldactone, will not work. Antihypertensives, conventional, do not work. They just need amiloride, a sodium channel blocker. And then there's the syndrome of AME, or apparent mineralocorticoid excess, again described more than 40 years ago. Phenotypically, it's identical to Liddle syndrome, very difficult to differentiate. They all have early onset hypertension, hypokalemic alkalosis, low renin, low aldosterone. Here they respond to mineralocorticoid antagonists, spironolactone or eplerenone. The genotype again was discovered more than 20 years later. Again, against a recessive gene. This is the only recessive gene that, and congenital adrenal hyperplasia. And this is a very interesting disease because there is an acquired form of this disease. And if you ever been to Holland, where licorice is consumed in very, very large amounts, they develop a licorice-induced hypertension. Licorice causes exactly the same thing that these patients have as an inherited disease. So the disease is due to mutations, loss of function mutations in the 11-beta hydroxysteroid dehydrogenase type 2. So this is an enzyme I'll show in a minute. Again, as I said, it's inhibited by licorice and carbenoxolone. This is an enzyme that, interestingly, in the mineralocorticoid, in the principal cell of the collecting duct, it converts cortisol to cortisone. Okay, again, it's unfortunate we can't point, but as you can see on the right side, cortisol is converted to cortisone, and cortisol has a very potent mineralocorticoid effect. So it's probably as potent as aldosterone because it circulates in very, very high concentration. So were it not for this hormone, 11-beta-hydroxysteroid dehydrogenase, it will remain very high. So this hormone converts it into cortisone, which has no effect on the mineralocorticoid receptor. So this is under normal situation. When this enzyme is missing, cortisol will circulate in high concentration and will lead to hypertension, again stimulating the mineralocorticoid and affecting the sodium epithelial channel.
Prof, could you conclude in 2 minutes, please?
Okay, finally we have congenital adrenal I thought I had 30 minutes. Congenital adrenal hyperplasia, which is, again, there are two types, type 4 and type 5. One is 11-beta-hydroxylase deficiency. The other is 17-hydroxylase deficiency. The phenotype is characteristic. They present with ambiguous genitalia in girls, and in boys, precocious puberty. Type 5, 17-hydroxylase deficiency is just the opposite, primary amenorrhea in girls and ambiguous genitalia in boys. They both respond to mineralocorticoid antagonists. The last syndrome is the Geller syndrome. This was recently described about 18 years ago. And again, it's a dominant trait. Again, early onset hypertension, exacerbated during pregnancy. This is a disease of pregnancy, really. And here there is a mutation, a point mutation in the mineralocorticoid receptor that changes serine to leucine, and it alters the receptor specificity to the extent that progesterone becomes an agonist instead of antagonist. Okay, so this is a summary of what happens to all these syndromes. Okay, you have the adrenal gland down here. You have syndromes of aldosterone excess. You have the AME, which is due to 11-beta-hydroxysteroid dehydrogenase deficiency. This is not working. Okay. Then you have the congenital adrenal hyperplasia I just talked about. Not working. Anyway, so can you change the slides? Okay, so this is the summary of the treatment. All these diseases, as I said, share one thing in common. They all have extracellular fluid volume expansion. They all have low plasma renin circulation. They all have low aldosterone, except for the familial hyperaldosteronism, as it's implicit. And the treatment really consists primarily of mineralocorticoid antagonists in most of these cases, except, of course, in Gordon syndrome, where thiazide is the treatment, and in Liddle syndrome, where sodium channel blockers is used. And finally, to summarize what I've been saying for the last 25 minutes, mutations in these transporters and mineralocorticoid receptor can mimic a state of mineralocorticoid excess leading to hypertension. These are the diseases: Liddle's, Gordon's, and Geller's. Mutations in adrenal steroid enzymes lead to their deficiency, lead to buildup of precursors such as congenital adrenal hyperplasia and AME. And then mutations in the aldosterone pathway lead to excessive aldosynthesis. Hormonal studies coupled with genetic testing can help in diagnosing all these diseases and apply early treatment. Thank you.